We're going to be talking about advanced directives. Krista and I are both going to be facilitating this with you today. And so my name is Bonnie Herman. I'm a licensed clinical social worker. I currently am working in palliative care and also do some private practice work focusing on illness and grief counseling. And I co-chair the Survivorship and Palliative Care Task Force with Krista and Carlin, who's also on this call today, as part of the Colorado Cancer Coalition. So this is really kicking off our webinar series. We have a couple more throughout this year, and then we'll have one in January as well, where we're really focusing on providing information about what palliative care actually looks like, and specifically what it looks like in Colorado. So we hope to dive deeper into the different environments that palliative care is available and how that looks both in kind of the city center, urban setting, and also in our rural and frontier areas. So we'll be focusing on some of that in June and in September. And then we have a couple that are geared more towards mental health and directly working with folks who are experiencing cancer, whether that's the survivor themselves or caregivers, and some specific interventions that are helpful. And also just kind of generally speaking, what kind of the emotional range is that folks go through from the moment of diagnosis through some more advanced cancer stages. So for any of those mental health workers out there who are on this call especially, or those working in oncology, we hope you'll join us later this year for some of those. And for the rest of our webinar series, we hope to be able to offer continuing education for social workers and hopefully for nurses. So we appreciate you all being on the call with us today. The reason we wanted to really focus on advanced directives, we just passed National Healthcare Decisions Day, which was in April 16th. And we wanted to be able to use this time to really hone in on some of the most common advanced directives that healthcare workers see and really see if we can improve the amount that are completed correctly. I think that's something that I've seen through my time in oncology and hospice and palliative care is that sometimes these directives just aren't quite completed correctly and then aren't really valid. So we want to make sure that we're doing the best that we can for folks and having them be as valid as can be. You'll see on this slide, and we have another slide later as well that has our web address that has the rest of our webinar series. And then also we welcome you to reach out to us, especially if you'd like to be more involved in our bi-monthly task force meetings and our subcommittees focusing on mental health and palliative care as well. So our objectives for today, we're going to focus specifically on some of the Colorado specific forms that are probably the most common ones that you might be seeing. We'll talk a little bit about when they're most appropriate to be used and looking at what it takes for a form to actually be fully completed and valid. We'll talk a little bit about some strategies and tips for discussing each directive when you're walking through this with someone. And I think that a lot of those strategies will extend to both the patients and clients that you serve, or if you're working with a family member or someone else that you might know in your personal life and talking about these things as well. So what is an advanced directive? So advanced directives, they're legal documents that provide instructions for medical care and generally go into effect when you cannot communicate your wishes yourself. We'll talk about a couple of exceptions to this, but in general, that's what we're talking about. And for our purposes today, we're specifically talking about medical directives. So sometimes when people say, oh, I've got everything in place, they are oftentimes referring to financial or property will that has been completed with an attorney, and that may or may not include things about a medical power of attorney or medical decision making, and most often would not meet the requirement for what someone's preferences are for using or not using CPR at end of life. So we want to be clear about that, especially when you're talking with folks who sometimes may think they've got everything all taken care of, but when we kind of comb through the weeds a little bit, that's often not the case. And it can be an opportunity for some more discussion about specifically what they have and what their wishes are. So we'll talk about the medical durable power of attorney. That's the name that it's called here in Colorado. In other states, or if you're hearing people talking about it, they may refer to it as just a POA, power of attorney, healthcare decision maker. It's got kind of a lot of different names that people may refer to it by. We'll talk about the proxy by statute a little bit, which is the process that's used if someone does not have a medical power of attorney in place, but they need a decision maker to help step up if they don't have capacity at the time that something happens. We'll talk about the advanced directive for medical and surgical options, which is a long name, but really just means the living will. And in Colorado, our specific form that talks about the use of CPR is the medical orders for scope of treatment, or the MOST form. Sometimes that's also called the PULST or a POST or something like that. Different states have it by different names, and it's part of the larger PULST program that was a kind of a national rollout, which has different names in different states. We'll talk about the CPR directive as well. That's still a common form that people see, but not generally the primary form that's used when talking about attempting resuscitation. And again, just to clarify, we're not really going to be focusing on any financial or property directives at this time. So that can be something, of course, that is important, and encourage people to seek out an attorney or someone else to be able to help guide them through that, especially if there's quite a bit of assets or something that they want to protect. All right, Krista's going to take us away for the power of attorney.
So when we're talking about the durable power of attorney, the medical durable power of attorney form, I think it's really important to know in Colorado that there is no next of kin law in Colorado. So there is no standard, your spouse is your decision maker, or your adult children are your decision maker. That does not exist. Most people assume, oh, if I go into the hospital, they'll call my wife and she'll make my decisions. And practically speaking, that may be how it happens. But if your wife shows up and your sister shows up, and they both want to make the decisions, neither one of them actually has priority. And so that's one of the reasons that we really encourage people to complete a power of attorney form naming their medical decision maker. So in Colorado, this form would take effect either immediately, if you give permission for your decision maker to make decisions immediately, or when you come to lack capacity. And capacity is a medical determination that's made by the medical team that you cannot understand your options, you cannot understand your choices and what the ramifications of those choices would be. And so the agent that you choose is bound to make decisions according to the wishes that you have expressed or in your best interest. And it's encouraged when you complete a durable medical durable power of attorney form that you have a conversation with the person you're choosing about what's important to you and what they would want to take into account as they were making decisions. Interestingly, here in Colorado, it also does not require a witness or a notary, so it can just be a form that you sign on your own. That is not the case in probably the majority of other states. I've lived and worked in both Missouri and Vermont, and in both of those states, either a notary or two witnesses were required to make the form valid. So if you take your MDPOA form out of Colorado, it may or may not be honored out of the state. So that's important to know. And then again, it also expires upon death or revocation. So if you complete one and you want to change your medical decision maker, you take your old form, you just write void on it, you void that form, and then you complete a new form. We're going to look at some of the sections that need to be filled out completely. And so this form that we're looking at is the kind of the generic Colorado form. There are other forms out there. There are 5 wishes. There are some hospital systems have their own forms, but this is kind of a generic Colorado form. And so it requires that you complete your name, the name of your agent, so the person you want to be your decision maker, their contact information. And that's more important than you realize, because if you have this on file with your physician and you go into the hospital and it doesn't have your agent's phone number and you haven't given them the phone number as a contact, they may have a very hard time getting in touch with the person that you want to make your medical decisions. So that's really important. Then you need to declare when you want your agent to make the decision. Is it immediately? And usually, practically speaking, that would mean that you, in combination with your POA, would be making decisions with the medical team. Some people do choose to defer that completely. Go talk to my daughter, I don't want to know. But most people, the medical team would have a conversation with the both of you. Or the POA would be responsible when you could no longer make your decisions. We recommend that somebody choose at least one alternate. That's the person who, in the event that the first person, my primary, is not available, then we have a secondary person to make those decisions. Not required, is not required, but it is recommended. So you can encourage, if you're assisting a patient or a client to complete one of these, you can encourage them to think about who else they might want to make decisions. That can be challenging often for people, especially if they're trying to choose between children. You know, I might make my spouse my primary decision maker, but if I've got a son and a daughter and they may have some kind of rivalry issues, like it can be really hard to make a decision. So there are ways to add little instructions like, please make my children make decisions together. There, you can see the instructions to agent that are also not required, but recommended if you have certain preferences that you want to be followed or taken into account. If you are, for example, like a Jehovah's Witness and you want no blood products, then there are specific medical directives for Jehovah's Witnesses that can be completed and should be completed and kept on file. And then the last thing that is required is the signature and the date. And without a date, it is not valid. Without a signature, it is not valid. And then it has a backside, which is optional as well. And this is where you can have the signature of the witnesses if you want to have them, or the notary. This is really recommended if you think that people are going to fight over who actually gets to make the decisions. If you have, again, 2 kids and you really want, you know, child A to make the decisions, but child B is going to come and complain about it, then it's really helpful to have a witness or a notary say, yep, no, I saw your mother sign this. It was not under the duress of someone else. And so that's been completed. Like I said, not required. If you do have witnesses, it cannot be someone who is on the form. So it cannot be one of your decision makers. It can often not be a healthcare worker, depending on the hospital system. So sometimes you need a witness. They may pull a random neighbor, and it can't be anyone who is financially responsible or would have any financial benefit out of like your passing or something. That's not an option as well. So the proxy by statute, this is what the hospital uses typically, or the hospice or the agency that you're working with, to name a decision maker in the event that a POA has not been named and we don't have one single person. What that usually looks like is the social worker, it's usually a social worker, becomes responsible for gathering the interested parties who may want to make decisions for a meeting with the medical team to allow then the medical team to identify that person to make decisions. There is a form that can be completed and put on file. And it's really intended to be for that particular episode of care, not necessarily a long-term appointment. If we have someone who doesn't have a medical decision maker and we anticipate that they will not ever be able to make their own decisions, then we would recommend that that person would pursue guardianship through the courts. And that would allow the court to name the person who would be making not only medical, but also at that point, likely financial decisions about living, those types of things. And then I think we're going to talk a little bit about the living will next. And the living will is really specifics about the medical care that you would want to be provided in the event of usually a terminal illness or a persistent vegetative state. This one is the one that kind of comes into play after the Terry Schiavo experience that everybody watched, gosh, many years ago now, where the family fought over how would she have wanted to be taken care of. And so the living will allows you to express those specific wishes. This is recommended, like the MDPOA, for anyone over the age of 18. So this is to be completed prior to a diagnosis of a terminal illness. It is something that then should be combined often with the MDPOA, and some places have those two automatically combined. This does require witnesses, and so again, cannot be part of the healthcare team or part of the family. And it's really helpful for if you're working with someone who really doesn't have a decision maker. They really don't have someone that they trust, or they're living in a facility and there is no more family. Then it allows them to express their wishes, and it is supposed to be followed by the medical team. So this is a declaration that the medical team should be using to guide your medical care if you don't have a decision maker. So we'll look a little bit at that. So this allows, if you look at this, it feels like it repeats a little bit, and it gets I'll tell you, the first time I looked at it, I thought, why are we saying the same thing twice? But the key is this allows specific wishes related to a terminal condition. So i.e. Not expected to get better, probably at this point not expected to regain the ability to make decisions. And so it allows preferences related to life-sustaining procedures. So that can be artificial nutrition and hydration, which is number 2. That can be ventilator support if you're in an ICU and on a ventilator. And it allows you to either direct that these interventions can be withdrawn or withheld, not including any procedure necessary to provide comfort or pain relief. It also allows you to specify an amount of time. Like if you say, well, give it a try, I want to be on, you can try a ventilator for 1 week, and if it doesn't get better, then please extubate at that point. I will warn you, having worked in a hospital for years, doctors don't love those artificial deadlines. They don't usually mean much because they don't really take into account an individual's situation. But if you want to be clear that I'm willing to try it, but no more than a week, you can put it there. Artificial nutrition and hydration, also very important to express a preference related to that, because that can be a really difficult decision for powers of attorney to make, especially if you haven't had specific decision conversations about it. So either to be stopped or not started, or to be continued for a period of time. Or if you want it, if this is something that's really important to you, maybe it's part of your religious beliefs, or just something that you just can't imagine going through kind of the dying process without ongoing artificial nutrition and hydration, you can choose to have it continued. Very often then, if it becomes something that is no longer beneficial, or it's starting to cause more harm than good, then a medical decision to stop it may be made, but it would be less of that would be a decision that's being made in combination with the physician and the decision makers at that point. And then here you repeat the very same thing, but you do it for a persistent vegetative state. And so that is when you are, you're not able to make your decisions, but you're not actively dying. You're not able to eat and drink on your own. This is not referring to oral feeding. This is not referring to things that you can swallow or chew on your own. This is referring to things that are administered by tube. And so in the event that you are not actively dying, but you're not expected to recover from this persistent vegetative state, you can express your wishes related to life-sustaining procedures like intubation and artificial nutrition and hydration. And again, you have the same options to not continue it, to continue it for a period of time, or to continue it indefinitely. And then in the event that you do have an MDPOA also, we really want you to note that on this form so that they have it. Again, not required to have both, recommended to have both. And then this one does on the back side require signatures. It allows you to offer other people that you might want discussions to be made or to be had with. Although if you have other people you want to discuss it with, you may want to just encourage them to name a power of attorney at the same time. Preferences for organ donation are allowed here, not required. And then what is required is your signature and date, again, and then the 2 witnesses. And without those, then the form is not valid. Especially 2 witness or a notary. Without one of those, it is not valid. Am I correct in that, Bonnie? It is either or, not both.
Yeah, that's my understanding as well, either or. So I think the notary then like trumps the need for witnesses. As we're going through, feel free to pop any questions that you have into the chat. We'll go through the most form next and a couple other things, and then definitely have time for questions at the end. So we can circle back to anything, especially if kind of as we're going through, you have questions about kind of, very specific details or kind of the nitty gritty. We'll be happy to revisit that. All right, so the medical orders for scope of treatment, it's most often referred to the MOST form, and in Colorado, it is that bright green form. Different states have different colors of forms, but usually there's a bright color so that it is easily recognizable, especially to EMS if they're responding to a home situation. But it's used for folks in any type of setting. So whether you're at home, whether you're in a nursing facility, assisted living, in the hospital, it's most commonly like an in-hospital DNR. So not necessarily the MOST form has been completed, but something else to indicate what someone's preferences are if resuscitation should be attempted or not. So the medical order scope of treatment differs a little bit from the living will and the power of attorney in that it's intended for people who more so have a serious or terminal illness, who are chronically ill, who are in and out of the hospital, having a lot of interaction with different healthcare providers, things like that. And it gives direction regarding whether someone would like CPR to be attempted, what types of care they would want up until their death, up until their heart and lungs stop working, and also a provision for artificial nutrition. This differs a little bit from some other states as well. Some other states just kind of leave off the artificial nutrition and don't even have that as part of this type of form. It requires a signature by an MD, a DO, a nurse practitioner, a physician's assistant, one of those to be valid. And so then it becomes a medical order that has to be followed. That differs as well from kind of this terminology that we use of advanced directive. And for our purposes, we've kind of lumped it all together, but it is a bit different in that it does become a medical order versus the healthcare power of attorney and the living will are a little different in that way. The medical order for scope of treatment, it's intended to travel with someone between care settings so that we're honoring what someone's wishes are regardless of where they are. And certainly sometimes people's preferences change if they're in the hospital versus at home, something like that. They may decide that they do want CPR in that setting or that they would want some other interventions. But in general, it's intended to travel with someone. And so it's very important that it's completed entirely and signed by the doctor so that it will be recognized and honored in other settings. Like other forms, it's still a living document. So it's okay to review it, to change it, to revoke it. It's really up to that person as long as they're able to make that decision, or their medical power of attorney if they're no longer able to. And because it's on that standard green paper, any copies, if they're on regular white paper or anything like that, those are also still valid. But as much as possible, we try to encourage people to have it on that green paper so that it's easily recognizable. And most of you will probably know, but in general, it's encouraged to put it on someone's fridge, on the back of their door, their bedroom door. Those are kind of the main areas that especially emergency responders are trained to look for so that they can kind of see that quickly. The other thing to remember is that sometimes people have put a preference for CPR in say a larger document, like one they've completed with an attorney that has the power of attorney, the medical power of attorney, has the living will, and they've put a statement in there about CPR, but that is not a medical order at that point, right? So when it becomes something that's documented on the MOST form and signed by a provider, that becomes a medical order. And so that is still different than if someone had completed a directive outside of that. So sometimes, especially with folks who are on hospice, you would have that discussion with them and they're like, oh, I've completed that already. I don't want to do any more paperwork, but it's still different, right? This is a medical order that we're talking about that has to be followed. So we'll go through the most form here, like we did with the power of attorney and the living will. You'll see, of course, the demographic information that's completed up here at the top right corner. And the most form is broken down into a couple of different sections. There's 3 sections that talk about medical treatment, and the others are for what type of who you've had the conversation with. My apologies. So section A, we're really talking about when someone's heart has stopped beating and when their lungs stop working. So both of those have to be the condition for section A to be referred to. So when they have died, this is asking if someone wants CPR to be attempted or to have allowed that death to happen naturally, to not attempt to bring someone back. I heard this described recently by a physician of, let me die once, I don't want to have to die twice. And so one important thing to remember, and you'll see this in the next section, it'll make a little more sense. But if yes, CPR is selected, then full treatment in section B has to be selected. Because if we were to attempt resuscitation, they're going to need to do other invasive measures after that. They might need to do intubation, chest compressions, mechanical ventilation, those types of things. And so if someone had CPR, but then say comfort care, it wouldn't really make sense because you'd bring someone back and not be able to do anything and then bring someone back again, or attempt to at the very least, right? The other thing is to really try to check for a full understanding of CPR and what it actually means and what it looks like. Now, I know that most of you on this call, if you've had even a snippet of a conversation like this with someone, it can be really delicate and it can feel really scary. So it can be helpful to both educate yourself about what CPR means, what it looks like, and really get an understanding of what that person is coming to the table with. Because a lot of times the way that we think about CPR is not really how that looks when it's played out. It's not fully based in the reality of the situation, especially when someone has they're of advanced age, they have a serious illness, or they have multiple medical conditions that complicate the likelihood that it could be successful. So I looked into a couple studies about this. I think many of you might know that the general successful resuscitation rate, especially for people who have advanced age and multiple medical conditions, is generally between 2 and 5%. It's usually kind of on that lower end, especially if someone's heart and breathing were to stop in a home situation, because then we're waiting on the response time for additional interventions to take place. If someone is in the hospital or they're already in the ICU, they're already on the surgery table, they're already in a condition where everything's already available, it may have certainly higher percentages of successful resuscitation. And so our society often does not really accurately portray what CPR looks like in the media. Oftentimes you'll see people walking into the hospital on a medical drama show, and then 2 days later they're walking, they receive CPR, and 2 days later they're walking out and they're fully able to resume their lives. But especially with the folks that we work with, especially if they're stage 3, stage 4 cancer, they have other issues that are going on, it's pretty unlikely, quite unlikely, that someone would be able to regain their prior level of functioning. One study found that only 2.7% of patients thought that the success rate of CPR was less than 10%. And another found that 81% of respondents, and these were people who were age 70 or older and actively hospitalized at the time, thought that their chance of surviving CPR and leaving the hospital was over 50%. And that 25% of those people believed that there was a 90% success rate of them being able to receive CPR and walk out of the hospital. So we can see that there's definitely a lot of misalignment with what someone's expectations are and what the likelihood is of them being able to fully engage in their lives again. So section B here, this you'll see with the asterisk is when someone has a pulse or they're breathing. So their vitals have not stopped yet, and they're still fully alive. So if someone is selected yes CPR in the first one, they have to select full treatment here. So that would include things like intubation, mechanical ventilation, includes the intensive care unit, those kinds of things. If someone selects no CPR, then they can select any of the options in section B. They could select full treatment. Maybe they want everything up until CPR. Maybe they want selective treatment, so they might be okay with going to the hospital. They might be okay with receiving antibiotics or fluids, especially maybe in the case of a pneumonia or something like that, but they wouldn't want to be intubated. They wouldn't want mechanical ventilation, and they wouldn't want CPR. So that could be an option as well, where someone might still want to go to the hospital, especially if it's something that could be managed and they could go back home or to wherever they were, but they would want to avoid the intensive care unit and, again, intubation and CPR. Comfort focused treatment here, that is generally when someone's kind of most aligned with hospice care. We would likely see them selecting no DNR, no CPR, and either selective treatment or comfort focused treatment. But if you have a person who is at home, they're really saying, gosh, I don't want to go back and forth to the hospital anymore. I don't really feel like I get much better when I get there. I decline a bit more each time. I really just want to be kind of left alone, and I want to be peaceful and comfortable. That's really going to most align with no CPR, comfort focused treatment. And as we move into section C, that situation would probably also align with no artificial nutrition by tube, but of course it could differ a little bit for folks. So section C specifically talks about artificial nutrition by tube. Of course, this is not talking about if someone's still able to eat or drink or take things by mouth. That's completely separate. Of course, we would always offer that, and especially for comfort focused care. So it gives someone the option to select if they would like it permanently, or if they're okay with that, especially if someone is already receiving that, if they're not able to eat by mouth. There's an option for if someone would be okay with it short term, especially if it's something that might be able to be reversed. Say for like a head and neck cancer, where maybe we are expecting them to be able to be treated and recover. Some of those folks maybe have a feeding tube short-term temporarily, with the goal that it would be able to be removed and they'd be able to eat again on their own. Or someone can select no artificial nutrition by tube. So you'll see a box here at the bottom about a living will. If it indicates yes to artificial nutrition by tube, it's more difficult for a power of attorney or a proxy to be able to say no later. There's specific circumstances in which that happens. Mostly that there has to be a conversation with two physicians to be able to remove or stop artificial nutrition by tube. So I've been talking a lot, but we're wrapping up here with our medical order for scope of treatment. Section D is talking about who this was discussed with. So if the patient was there, if the POA was there, you can put in any of those folks. And for the most form to be valid, it needs to be signed by either the patient or legal decision maker. They can print their name, write self, or whoever it was. It needs to be signed, and then it also needs to be signed by a provider. So the main pieces here, and where we often see some disconnect, is that it has to be signed and dated by the patient or legal decision maker, and the physician signs and dates it too. So those things need to all happen for this form to be valid. If there's not a date that the physician put there or that someone else put there, it's not technically valid. It should still be regarded as what the patient's wishes are, but you should make every effort possible to make it, to get one that's valid and in place. Another thing to keep in mind about the most form is that a telephone order or a verbal order is perfectly legal here as well. So, especially if you're working in hospice, you're in the home with the patient, they're declining really quickly, and it would be really difficult to get the signature and bring back the physical form for someone. You can get a nurse who can take that telephone order, document that here, and then follow up later with the physical signature or the electronic signature, whatever it is.
And Bonnie, we've got some good questions related to the most. And
yeah, please.
One of them was was there a time frame that you have to have the MD signature on the most form? I've been told it's valid for 30 days without it. I'm wondering if that's in the case of the verbal order.
Yes, that's the direction that I've seen as well, is that ideally it would the physical signature would be followed up on within 30 days.
And then I'm going to jump down to one of the others, which is what happens if family members call 911 and want life-saving measures, and even when the individual has a MOST or a CPR directive. And this is actually a really interesting question, and I think we see a lot of this. Practically speaking, this order is worth the paper that it is written on. So in the event that EMS does not have a copy of it, they cannot follow it. So if you have family members who choose not to provide the form to EMS, then EMS will provide all of the medical care that they are responsible to, and the person gets to the hospital. If the form is there, if the form is on the door and EMS sees it, then they are responsible to follow that form based on the fact that it is a medical order. So it's really important to talk with your patients and clients and families to say, hey, this is important to me. This is what I want. I know it may not be what you want. I know this is hard for you, but I know that you love me and you want to do what I, want. Whatever the conversation is to help the family come to terms with the fact that honoring their loved one's wishes is the best way to provide their care. But like I said, if they don't hand it over, then it's like it doesn't exist. So that's really important.
Yeah, and the other thing, just to kind of follow up on that piece, is sometimes people will have the MOST form, but either they or the family doesn't want it to be, say on the fridge, because it's a reminder every second of every day that that's what's going on, and that can be hard for people. But I've had that happen where a patient had it, kind of stashed away with their medical power of attorney, and they did have EMS come out to the home, and then that wasn't honored because it wasn't fully visible. So, this can be where there's a lot of gray in that, but ideally they should be honoring what the medical order is at the time if it's visible to them.
And then we had another question: what happens if people completed multiple advance directives or legal documents over time, but their preferences conflict with one another? Which ones are honored?
That's a good point. In general, the most recent one will take precedent, but there are some little nuances, especially if they conflict. So if someone said, say yes in a living will beforehand and it was completed by the patient, but then a MOST form is completed later and it's completed by, say, the proxy, if there wasn't a medical power of attorney in place, then my understanding is the living will should be honored unless there's like two physicians who say that, medically this is really just prolonging someone's death and not providing any chance at a reasonable recovery. So it gets a little bit sticky. We have some resources that'll be at the end, and they have some more of the specifics, especially about kind of which directive to follow if there is conflicting information. So you'll see a little bit here on the screen right now, which is the back of the MOST form. There's some good information here, which I actually didn't quite realize until I fully read through it. But one thing to point out is that a completion of the MOST form cannot be conditional for admission to or receiving medical treatment from a healthcare facility. I think in practice, that's not really how people do it. A lot of times you'll see, nursing facilities requiring it, or I've even heard hospices sometimes trying to require it as well. But it is someone's right to be able to not complete a MOST form. And ideally then we'll have really more of an in-depth conversation about what is some of that opposition to completing one. And then we'll have some other resources as well that kind of go into that a little more in depth. And then on the bottom there, you'll see that the MOST form, you can keep the same form and then review it over time to still say, yes, this is what someone's wishes are. If the wishes change and it would be confusing to cross things out, it's probably best to just complete a new form. So the CPR directive, we won't go through it like we did the MOST form. It is something that you may still see. And again, in the resources later, we'll have a link to one that you can see what it looks like. This one's a little bit different in that it gives directive about CPR short of a full arrest. So when someone has no pulse or is not breathing, or the breathing malfunctions in some way. So it's a little bit of a different threshold for when CPR can or cannot be used. it must be signed by an MD, and sometimes people have like a medical alert bracelet where they've, say, sent in a copy of their CPR directive and they have the medical alert bracelet, and that is okay as well. For EMS should be able to see that and be able to honor that too. Again, I would just suggest that people have the CPR directive or the most form physically available as well, so that it can be verified.
And then we had one more question, Bonnie, about how do I go about getting an elder a guardian when they have no loved ones? And I want to direct you to the Office of Public Guardianship for the state of Colorado would be a good place to get information about that.
Yeah, it is a very tricky one for sure. Sometimes I would really see also what type of, if you're working within an agency setting, what type of policies or procedures do they have in place, or are there other supports that they can access as well. Sometimes there's using an ethics committee or something, and that helps to kind of move the process along. But it's not an easy process for sure. So as much as these things can be done beforehand, before someone loses capacity, obviously that's the best case scenario. All right, Krista, take it away.
So when you have people who have completed, or if you have completed your advanced directives, what should you do with them? We want to recommend that you make copies, that you have both an electronic copy and paper copies that are kept with your information, with your documents, given to your decision makers. So all of the kids, and given to the people who might have interest in your care, even if they are not your decision makers. So we would encourage having your clients share that with all of their children, for example. And then there's no question, should it come up later, who the decision maker is. That can ease some of those conflicts later. Recommend that you give it to your healthcare provider. Most offices now have a way to upload it into the electronic medical record. Some you're able to upload it yourself into the electronic medical record through their like MyChart type of program, so you can look into that. Colorado is somewhere in the process of establishing a registry where anyone can upload it to the registry, or an appropriate person can upload it to the registry, and then that can be accessed by any medical system that you got into. Because, for example, if you are seen at UC Health, but you get admitted to a Health One facility, they may or may not have access to your documentation. They may not share a medical record and be able to see that across platforms. So here are some websites where you can get the information on the forms that we've been talking about. These slides will be available so that you can get these. CDPHE, the Colorado Department of Health, what's the E?
Environment?
The CDPHE has a lot of these forms and access to those. And we wanted to talk about some of the resources that might be useful. One of the biggest challenges around any of these documents is the conversation, and how do you raise it either with your own family members, or how do you raise it with people that you're working with professionally? And one of the strategies that we often encourage is to make it a family event. So it becomes not something that's about an identified patient or that one person, but it's something that we all do. Everyone over the age of 18 sits around and completes the documentation. Then there's an opportunity for discussion. There's an opportunity for people to know what their wishes are, who their decision makers would be, and to normalize this as something that we as a family and a community can talk about. The Conversation Project is a really good resource for starting those conversations. They have a number of different booklets. They have a conversation starter kit if you've got an elderly parent that you want to start the conversation with, and ways to kind of gently ease into the discussions when people are not eager or comfortable having them. Compassion and Choices is a good organization. They have a lot of information about the medical aid in dying. We didn't talk anything about that. Nothing that we talked about today is related to MAID, but that is legal in Colorado. So there's good information there. They also have some good resources for people to create advanced directives in a setting of dementia. There are certainly different conversations and different things to think about when you're dealing with dementia. And so they have some good resources there related to that. Colorado Care Planning We'll also give you some information about how to make those decisions and paperwork and such. Prepare for your care. If you're working with a population that has a fairly low health literacy or is not as comfortable on a computer, they have a really good step-by-step program. I mean, as simple as how do I use this program to complete these documents step by step. And so that can be a really good resource. 5 Wishes is a national advanced directive. It's actually something that you have to pay for. And it's a very detailed document that allows people to go into a lot of details, kind of depending on the situation that's presented to them. It's honored in most states. I'm not going to say all, there may be some that aren't, but it is honored as a kind of a combination directive, medical advanced directive, POA, and living will. We talked about CDPHE, and then Civic is the Colorado Center to advance healthcare in Colorado, and they've been doing a lot around advanced care planning and palliative care, and they have some good resources. And then we just put the medical alert, MedAlert on here. It's a resource for things like medical alert bracelets, which are honored as CPR directives here in the state of Colorado. So if you're wearing one that says no CPR, they may not honor a tattoo across your chest, but EMS will honor a bracelet. So that's just to be helpful for you. Some of our references, let's see. And yes, we are going to share the slides at the end. And we thank you all for listening to that. We'd love to take any more questions, either in the chat or if you want to raise your hand or unmute yourself and just speak up. And the link to where the slides will be probably early next week is in the chat. And it's on our Cancer Coalition Survivorship and Palliative Care webinar series page.
I have a question. If you, in the state, I live in Colorado, so I work with patients here. If you had 1 or 2 of those forms to choose, that would be the most beneficial. Like if someone just gets overwhelmed with all the different ones, which one would you recommend?
I would say the medical power of attorney.
Okay.
Yeah, because even in the case of conversations about CPR, then at least healthcare workers know who to talk to about that if someone's not able to talk about it themselves anymore. So I would say the power of attorney, which is great because sometimes that's the least threatening conversation to have, right? We can all picture a circumstance in which you're driving down 25, which is a hellhole, and you get into a car accident. They need to know who to call. So I think they can be applicable to anyone.
And we have a link to an evaluation in the chat too, so we'd appreciate that. We are going to aim to provide some CEUs for our upcoming webinars. This one was a little quick to be able to do that, but so keep an eye out for that, especially if you need social worker or nursing CEUs.